Garrett Regriff here at Pure Plastic Surgery for another Thursday Thoughts. Today we're going to be going over some of the different incisions we do for different breast procedures. This is something I always get some confusion on when my patients come in, asking what type of incision they're going to be getting for different types of procedures that we do for the breast. So we're going to be going over all of that today. So let's start with breast augmentation. What that consists of is a very small 3.5 centimeter incision, just large enough that we can fit an implant through. And there's a few different locations surgeons can make those incisions. One is underneath the areola. Another one is up in the armpit. And then the most common way and what I do is in the inframammary fold. So there are reasons why I do not do these two incisions, through the armpit or through the on the border of the areola, and that is because there's a higher risk of developing capsular contracture with a breast augmentation when using either of those approaches. What is capsular contracture? It's that abnormal scar tissue that can form around an implant, and it's a problem that's just best to avoid it as much as possible. So that's why I only make my incision through the inframammary fold, so the fold of your breast. Again, a 3.5 centimeter incision, very small. It hides in the crease of the breast. It's basically not noticeable after a few months of recovery. All right, so that's for breast augmentation. For breast lift, or let's say breast reduction, let's start with that. For a woman that comes in that has very large breasts and wants to reduce the size of the breast, the most standard way of doing a breast reduction is doing the anchor incision, which is around the areola, down vertically, and then along the fold of the breast, okay? There is a way of doing a breast reduction without the incision in the fold of the breast, but whenever you think about tailoring the skin of the breast, we have laxity in multiple different planes. So we have vertical and horizontal laxity. And if you do the approach of just the lollipop, which is around the areola and straight down, you often get bunching in the bottom portion of the breast that requires at least a little vertical or a little horizontal incision, or coming back at a later time to remove a small dog ear. So when I do a breast reduction, I always do this type of a technique where we're going around the areola, down vertically, and then in the fold of the breast. That allows me to tighten the skin in multiple different planes, so you're not left with any contour abnormalities after the surgery. And so when we're talking about a breast reduction, we're not only removing skin, but we're removing some of the fat and breast tissue that's underlying that skin to make things smaller and make everything tighter. When we talk about a mastopexy or a breast lift, oftentimes it's the same exact scar as a breast reduction. And so when patients come in, there's always some confusion about reduction or lift, and just keep in mind that they are actually very similar surgeries. The difference is the amount of underlying tissue that we remove. With a lift, we're removing mostly skin, sometimes a little bit of fat. With a reduction, we're removing the skin, fat, and some of the glandular tissue to reduce it. But very similar incisions. Again, there are different types of lifts you can do for very special circumstances. And a periareolar lift is one, or a donut lift is one where we just remove skin around the areola. This is reserved for patients that have only a very small amount of excess skin, or they need to lift the nipple just a few centimeters, up to 2 centimeters is the maximum I'll do this lift for. It's called the Benelli lift or the donut lift, and that results in a scar just around the areola. A lot of women come in thinking they'll be a candidate for just doing the periareolar lift, when in reality they're much better served with doing a more traditional anchor type incision. Then the next variation of this is adding the vertical component to it, where we call it a lollipop incision or a circumvertical mastopexy. Again, that's around the areola, and then just a vertical component. Again, it's a very select patient that's a good candidate for this type of lift, and I do them pretty infrequently because most of the time a patient really needs some of the laxity taken out of the horizontal plane of the breast tissue as well. And so if you're coming in with just a small amount of lift needed, sometimes you'll be a candidate for the periareolar or for the circumvertical lift. But most of the time I'm going to be doing some component of the actual anchor incision. The length of the incision that goes in the fold of the breast is different for different patients. If you have a lot of skin laxity and a lot of lifting that needs to be done, we're going to use the whole fold of the breast. If we're doing a more modest lift, we can get away with just doing a few centimeters of scar in the fold of the breast. I hope that clears up a little bit of the confusion about the different incisions that we do for different breast surgeries. Does anyone have any questions regarding breast surgeries or questions about the scars that we can use?
Yes. Just 1 second. Okay. How do I know if I need to separate operations for a reduction lift, then add implants?
All right. There's a lot to unpack in that question, but yeah, there's a few things that you can look at yourself in the mirror to determine if you're going to need a lift, reduction, or implants. Let's start with the implant or the augmentation. If your goal is to have upper pull fullness or roundness on the top of your breast, you need an implant. There's no way that we can achieve that upper pull fullness without an implant. So keep that in mind. Depending on if you need a lift or a reduction depends on how much breast tissue you have, and then the position of your nipple in relationship to the fold of your breast. So if you look from sideways in the mirror, you see your nipple and then the fold of your breast. If your nipple is above the fold of your breast, you probably don't need a lift. But if your nipple is at the level of the fold or below the fold, you're likely going to need a lift at the same time. And then the difference between reduction and a lift depends on what your goals are. If your goal is to be smaller, then you need a reduction. If your goal is just to be lifted but retain as much volume as possible, then it's just a breast lift.
What technique of stitching do you use for less scarring?
What kind of stitching do we use for less scarring? So all of our incisions are closed with absorbable sutures that are underneath the skin. Nothing that needs to be removed at following surgery. So everything's hidden underneath the skin, dissolves on its own over time. All my patients come out of surgery with steri strips on, which are special tapes over the incision, which is another layer of closure, almost like another layer of sutures. But with time, those sutures just dissolve and go away. After you remove those steri strips, the other thing we recommend to minimize scarring is a silicone product, either silicone strips or silicone gel over the scar. Helps keep the scars from becoming hypertrophied or raised up.
Doc, the same patient that asked about the implant, lift, and reduction,
Yes.
She asked again, so can you do all three at once? Because I was told that I need all three.
Yes, and we often do all three at once. So oftentimes the implant goes in, gets you that nice upper pull fullness, but the ptotic or the sagging breast tissue and the lower pull is what needs to be reduced or removed. And then repositioning the nipple and at the apex of the implant is the lift portion of that. And so yes, frequently we do all three of those procedures together.
Do I need to do a mammogram if I'm younger than 40 and have silicone implants?
No, you do not need to do a mammogram if you're younger than 40. If you have silicone implants, you should investigate your implants if they've been in for over 10 years to make sure there's no evidence of a rupture. You can do that either with an MRI or a high-resolution ultrasound. Just helps for planning purposes if we know if there's been a rupture of that implant when I go to remove it, so I can be prepared to clean up any of the mess that may be associated with it.
Okay. Do you offer or recommend silicone scar therapy, sheeting, and gel?
I do. So I recommend this to all of my patients, even though some patients may not actually need it. It's better to start the therapy. I know that you don't need it. But what silicone sheeting or silicone gel does it makes a moisture barrier above the scar, and that keeping that scar moist, it somehow promotes the scar not becoming raised. They don't fully understand the pathophysiology behind that, but they use the silicone because it's able to completely seal it off, and it really does help with keeping scars from getting raised.
Last question, Doc. How do I know if I need a leaf instead of an augmentation?
So again, that comes back to looking at yourself in the mirror to see where your nipple is in relationship to the fold of your breast. If the nipple is above the fold of your breast and you've just lost volume in your breast, then just an augmentation will be likely the right procedure for you. If your nipple is at the fold or below the fold, you'll probably need a lift and an augmentation. All right, everybody, please feel free to reach out to us at pureplasticsurgery.com for a consultation or any further questions. Have a great day. I'll see you next week.